Okay, so good evening to everybody. I hope my voice can be heard loud and clear, and everybody is fine.
Yes.
Okay. Okay, so I'm going to share my slide, and then we continue from where we left off last week. Probably we'll be able to finish this one today, and then start the other one. Okay. Okay, so um, last week we started healing, and we were able to consider the distinct processes of wound healing, distinct processes of healing for which we made mention of. Can you hear me? Somebody has, I think,
Yes, sir.
I just,
Yes, sir, we can hear you.
okay, so I think Regina Sasu can find help somewhere. I think okay. So I said last week we started with healing, and we defined healing that is a response to injury, but then it follows up on inflammation. And then we looked at the distinct processes of healing, the distinct processes of healing, and then for the processes, we said we had repair and we had regeneration. We had regeneration first, and then we had repair. And in terms of regeneration, let me go back at least to help those that got lost along the line, just bringing us to speed. But I'm not reteaching, please. I'm just trying to help bring perspective so that in continuing, people can be okay and can get what I'm talking about. Okay. So I defined healing and then said we had two distinct processes of healing, which was regeneration and repair. And then we said that for regeneration, the regeneration was actually a replacement of the lost tissue by a similar type. And then we also made mention of the other distinct process called repair. And we said that for repair, we are looking at the replacement of the lost tissue by granulation tissue. And it is the granulation tissue that matures to form what we call a scar. And I told you that regeneration actually happens in cells that were either labile or they were stable cells. And because for regeneration, the cell should be able to go through the cell cycle to be able to produce daughter cells. The proliferative capacity or ability of the cell should be intact. But when it comes to repair, we were looking at instances where the damage to the cell actually affected the basement membrane or the stromal framework. That means even if the cell was actually, the tissues are actually labile or stable cells, made up of labile or stable cells, they will not be able to undergo regeneration because the basement membrane or the stromal framework has been affected. And we said that for repair, it mostly happens to permanent or static cells, cells which cannot go through the cell cycle to produce daughter cells at adult stages, right? So we move on, looked at this diagram here, or this arrangement here, and I told you that tissue injury, and then we expect that the first response will be inflammation. And from there will be phagocytosis, so there will be the removal of dead tissue and injury, right? Or an injurious agents. And then from there, we said that there are two ways by which the replacement can be possible. And then the two ways, we had the regeneration, we had the repair. But I said that whether it is by regeneration or by repair, the important thing is that the definition for healing has been failed. And what do I mean by the definition for healing? The replacement of the lost tissue has actually happened. It has been replaced by either similar type or by granulation tissue. And then we try to look at what regeneration involves, and we said it involves migration of surviving cells into vacant spaces, and then proliferation of surviving cells to replace the lost tissue. Remember, I'm recapping. So, and then we looked at what regeneration depends on. We said proliferative ability, the fact that the degree of damage to the stromal framework, we have to look at that, and then the type and severity of the damage. Then we also considered the type of cells that undergo regeneration, which I've already said, labile, stable cells. We talked about healing by repair, which we said that in healing by repair, granulation tissue will be formed. There is always damage to the basement membrane and then even the submucosa. That is, if we are looking at the skin and then the gastrointestinal tract, respectively. And then we talked about the phases of granulation. We said there were 3 phases: the phase of inflammation, the phase of demolition, and then the phase of ingrowth of granulation tissue. And for the ingrowth of granulation tissue, we said that the most important cell type for granulation tissue formation was the fibroblast. And we said that the fibroblast will have to proliferate. So whenever we are talking about granulation tissue, we are looking at proliferating fibroblast and then formation of new blood vessel, right? We are looking at proliferative fibroblast and then proliferative blood vessel. And that is what actually we mean by granulation tissue. And so remember that we also said the fibroblast has the capacity to synthesize and produce what we call extracellular matrix components. And these extracellular matrix components were actually made up of the fibronectin, proteoglycans, collagen type 1, 2, 3, 4, and even 5, 6. And then we said that the fibronectin and then proteoglycans serve as the scaffold, like the foundation for the rebuilding of the matrix. And then we have the fibronectin binding to fibrin to serve as also a chemotactic agent for the recruitment of a lot of the fibroblasts and then the macrophages even to the site. Then we looked at wound healing, and we said that the healing of organs differ merely in terms of the degree rather than the kind. And that is where I told you that regardless of the organ in the body that is affected, all you need to appreciate will be the kind of cells that make up that particular organ. And you'll be able to tell us whether the healing will be by repair, and if it's by repair there, or if, by repair, then we know that there is the formation of granulation tissue involved. If the cells are actually made up of labile cells, they are made up of stable cells. And then we know that the damage was not that bad to affect the basement membrane or the stromal framework. Then we know that there will be regeneration for that matter. And you should be able to know that when we are talking of regeneration, it's just about similar type of cell replacing the lost cells. And in that, we expect differentiation, maturation happening. Okay. And then we looked at the types of wound healing. And in that, we actually talked of the healing by first intention, also known as primary union. And then we have healing by second intention, also known as the secondary union. Very important. And please take note that whether a wound heals by first intention or second intention is not determined by the process. It's not by whether regeneration or by repair, but it has to do with the type of wound. The type of wound. And we got to know that the healing by first intention, we lose few cells and the edges of the wounds are close to each other. They are well opposed, right? And then in terms of inflammation or inflammatory reactions, they are not intense. But if you are looking at healing by second intention, we said that you have a lot of cells lost, a lot of tissue debris here and there. There is extensive inflammatory exudates and then reactions, right? And then we expect the removal of all the necrotic debris and everything. And we said keenly was the fact that a lot of cells will be lost. A lot of cells will be lost. And so with this, if God forbid, but you are in the dressing room or you are in the ward and there is the emergency unit and then there is a severe accident and somebody has been rushed in, at the back of your mind, you should be able to know that this will heal by second intention or first intention, dependent on the quantum of tissue that has been lost. And you should be able to give a fair idea of how the process of replacement will look like, so long as all other things are intact. What I mean by other things has to do with other factors that can influence wound healing for good or for bad. Okay. And so we looked at the steps and we talked about the first 24 hours. We talked about Frimpong, look, I'll answer your, what do we call it? Question later. I'm doing a recap. So we go on. So in terms of we made mention of the 48 hours, right? We made mention of the 48 hours and then we move on and then got even to 72 hours. So for 72 hours, we continued getting to know the steps involved, right? Sorry, got to know the steps involved and all that. And we got to know of the granulation tissue in terms of large wounds, granulation tissue in terms of large wounds. I think we made mention of all that. We talked about all that. Then we have the day 5, right? We have the day 5 where we talked about angiogenesis will be heightened. Angiogenesis will be heightened. And then we go on to look at second week. We actually looked at the first month as well. And then we looked at healing by second intention into details. And here we said that the reparative process is actually slow, right? We said that it was slow. And then we got on to the fact that we have myofibroblast, which is actually a modified fibroblast, and we said it contains proteins which were actin and then myosin to help it in terms of its contractile nature. So there were contractile proteins like the actin and the myosin helping it performs its duty in terms of wound contraction. Then we looked at the factors that influence wound healing. We said we had two factors. We had two factors, and the two factors we looked at were the local factors and the systemic factors. Then we had the systemic factors. Then we moved on to look at the local, where we had the blood supply. We continued, we looked at infection, right? And then we moved on to mechanical factors, considered location of the wound, which has a strong influence on it, right? A strong influence on it. And then we go on to actually look at, foreign bodies, size and type of the wound. We looked at systemic effects, and we said that nutrition plays a role in terms of wound healing, whether there will be delayed healing or not. Mm-hmm. And then we move on to systemic disease, where we said diabetes, and I made mention of the fact that diabetes can cause the rupturing of the blood vessels and all that. And then we made mention of hormones, glucocorticoids, which have anti-inflammatory effects and has adverse effects actually even on epithelial regeneration, the proliferation of fibroblasts, and then the synthesis of extracellular matrix. So we are here today. Yeah, we are here today. So we go on with the complications of wound healing, And in terms of the complications of wound healing, we have two things to look at. In terms of granulation tissue formation, deficiency of it, and then the excessiveness of it. So in terms of granulation tissue formation, there can be deficiency or there can be excess of it. And it is out of the deficiency that we have wound dehiscence, wound rupture, which actually is common after abdominal surgeries, especially when there is an increase of abdominal pressure. But most of the time, you see that the cause of that rupture is simply because of the inadequate vascularization, inadequate formation of blood vessels. Remember, we said that granulation tissue is simply fibroblast and then proliferative blood vessel. And so if one of them is inadequate, right, then that means there will be deficient granulation tissue formation. The possibility of the wound gaping and all that is very high. And so please take note of that. As we said, it is actually after abdominal surgery. There are certain people that have CS, and then when they go home, while granulation tissue is being formed, before long they apply or exert pressure around that area in terms of lifting something or bending or something. Before we know it, and then they have to be rushed back to the hospital because there will be tears here and there. And so get to know that when you have such situations, possibly there will be deficient granulation tissue formation. Then we have excessive granulation tissue formation, where it's the opposite of what we talked about, right? Where we expect that the granulation tissue that will be formed, and here we are looking at, just like I said again, we are looking at the blood vessel, we are looking at fibroblasts, we are looking at the extracellular matrix components, and they are laid in excess, right? So we have what we call the exuberant granulation, or we have what we call the proud flesh. And this actually prevents normal epithelialization. If you remember the steps we talked about, we made mention of epithelialization, where the epithelial cells would grow to fuse in the midline like that, like we talked about. And so in situations of excessive granulation tissue formation, in the situation of proud flesh, in the situation of exuberant granulation formation, we don't expect the edges of the wound to be opposed or to come together, right? And so if we want to restore the continuity of the epithelial cells, then there must be some form of excision for that to be possible. Okay, so we have hypertrophic scar, like I have shown you here, a picture, just for you to appreciate what is happening. So in situations like this, you are practicing already. You should know that then definitely you have the granulation tissue forming, but then it forms in excess because you have excessive collagen deposition. That has led to the place being raised like that, raised beyond the normal edges of the skin. Then we have keloids. And these are actually inherited tendencies. They are inherited tendencies to produce excessive amount of collagen, particularly prevalent amongst blacks. And it's interesting to note that when it comes to these keloids, they grow beyond the skin. They grow beyond the skin. People go and barb their hair, and when there are cuts, before you know, you have excessive collagen depositions. I did locum somewhere some time ago, and then there was this gentleman that used to pass in front of the hospital. When the place was less busy, we had somewhere we could actually, some barricade was there like that. It was a story building, so we just relaxed there, and then we are watching and observing people pass and what is happening in the streets. And there was this young man that used to pass in front of the place to go and then buy himself some dehu or some food like that. And he was one of those guys who dress with bandana and those baggy jeans and all those kind of things. So I don't know what came over him. He decided to go and do piercing. So he went to do piercing just so that he can put earring, not knowing that keloids were waiting for him. So before some few weeks, we saw that there were keloids, excessive amounts of collagen deposition that had caused the skin to raise, right? As a result of that. And then after some weeks, God had given him an earring. He had a lot of that, right? He had a lot of that. He had a very huge one around his ear, a very huge one around the ear loops like that and around the ear. And then he went and then they had to use radiations to just take it off. But then these things, they come back again. They grow back. So it's just now he had to now learn how to turn his cap to cover the keloid. Mm-hmm. So that's just my small story to just tell you. So please get to know, because these things is prevalent in blacks, especially the males, right? And they have the tendencies of, even when you have excised it, either by laser or whatever it is, at the end of the day, it grows back. No, it grows back. It grows back. Yeah. So please take note of that. I remember some time ago, some students shared with me that there is a stone called blue stone, which has the capacity to actually regress keloids. It was actually a midwifery class, and then they said when the women give birth like that, and then actually if it was a CS, and then they find these keloids or tumors growing like that, they have this blue stone they sell in the market. I told them that we'll have to do a research to know what component, what chemical or whatever is in there that helps regression of keloids. Okay. So we go on even with, we know there are drugs. Okay, so somebody is saying yes, it's true. Somebody is saying if it can be cancerous. Well, no, as keloid, no, it's not cancerous. Yeah. As keloid, no. Because if you look at the composition here, we are talking of just collagen deposition, but then in excess, leading to the fact that there will be a dermal mass and then a raised scar. But then we also have desmoids, right? And in desmoids, we are looking at exuberant proliferation of fibroblasts and other connective tissue. And these ones, they are not raised beyond the skin, right? Desmoids are inside there, inside of the skin, but then they invade surrounding tissue. They invade surrounding tissue. Then let's move Sorry, I think the network dropped and all that. So let me reshare my slide. Okay. So now let's come down to fracture. Let's come down to fracture, right? And then for fracture, what is the problem? Somebody is asking, Selena is asking if the things used for dressing wounds contribute to scarring. As research has it, there is no proof of that. There is no proof of that. Because in terms of, hey, I have a lot of questions like, okay, because in terms of the dressing of the wound is just to take away the, if there are infectious agents that the wound has been exposed to, and to take away the adnasal structures and some debris here and there. And then after that, cover it and add all that needs to be added to help with the whole healing process. Yeah, so there is nothing like that. I said that with regards to the desmoids, they actually are not dermal masses. You find them within the skin, right? But they invade surrounding tissue. That's all I said. I just made mention of the desmoids and then talked about the contracture, right? Which I related to bends. That was the only thing. I think I have a hand here. Somebody's hand is up. Finoria, Nyamido.
Sir, sorry, but I was also going to say the same thing which you have already repeated. So okay, sorry. Thanks.
Okay.
About the desmoid. So.
Okay. Okay. Then you can please put your hand down so that. Okay. So we move on to fracture, right? No, I think one guy asked the question about the healing by tertiary intention. And he's asking why we never made mention of that. If you are to look at that, it's actually a wound management technique. That's why we didn't talk about that. Okay. Let me continue. So with the fracture, we are looking at a break in the structural continuity of bone or periosteum. We are looking at a break in the structural continuity of bone or periosteum. And please note that whenever we look at fracture, we are looking at fracture healing. It's like talking about regeneration. Because you see, when we look at fracture healing, we expect the cells of the bone, where we are looking at the osteoblast, the osteoclast, and then the two main ones are the osteoblast and the osteoclast. Because in fact, even when we make mention of osteocytes are matured osteoblasts. Osteocytes are matured osteoblasts. Osteocytes are matured. And so we need to take note of that. But when we also look at the osteoclast, when we look at the osteoclast, the other name for osteoclast is actually bone destroyer. It's called bone destroyer. When osteoblasts, whenever there is a break in the bone, whenever there is a fracture, we expect the osteoblast, right, which has proliferative capacity, to proliferate and then produce more of the osteoblast, to fill the fracture site. That is when the inflammatory processes have gone on and all debris have been removed and all that. And then when the osteoblast overlays, then you have the osteoclast, which is also known as the bone destroyer, activated to help with remodeling. Apart from the fact that remodeling can also happen with exercise, right? with exercise when the time is right. And so please note that the osteoblast will proliferate and then would lay, but then the osteoblast can overproliferate. And that is where the osteoclast comes in here. When the osteoblast has done its part of proliferating to replace the cells that were lost, an interesting thing would also happen. And the interesting thing will be the fact that when you have the osteoclast activated, now it would ensure that all the excess osteoblast, when it's activated, is able to actually destroy as much as 100 to 1,000 osteoblasts at a go. And that is why the excesses can be broken down as a result of the activation of the osteoclast. Please take note of that. And when there isn't any fracture and you have the osteoclast activated, they can be the reason for osteoporosis. Yeah. And so take note of that. Whenever you have the osteoblast laying precept upon precept, you have it proliferating for more of it to fill the vacant space, and it matures, it becomes the osteocytes. And when they mature, and then you have the osteocytes, the remaining osteoblasts rest in the lacunae. Okay. And so we continue. So let's look at the types of fractures. Let's look at the types of fractures. And here you have the hairline, you have oblique, non-displaced, and oblique displaced. Then we have linear fracture, you have the comminuted, you have spiral, and you have segmented. When you look at other books, they categorize these ones into complicated and uncomplicated fractures. Yeah. So you have the hairline, you have the oblique, you have the oblique displaced, oblique non-displaced, you have the linear, you have the comminuted, you have spiral, and you have the segmented. Very important. Now let's take it one after the other and look at certain information. I already told you that in terms of healing of fracture, we know it happens by regeneration. Yeah, regeneration and then remodeling. And so we have three phases, just like we had three phases in terms of granulation tissue formation. This too, we have three phases. The first phase will be the inflammatory phase, which lasts actually for 1 week. We have the reparative phase, right? We have the reparative phase, which is actually the phase for the replacement, right, of the lost tissue. And then we have remodeling, which lasts from months to years, which lasts from months to years, right? Which lasts from months to years. Please take note of that. So we move on, and then I have a diagram here to help you appreciate it properly. So we have steps in fracture healing again, and down here, you will see inflammatory stages, and it starts from the day 0 down to the 5 to 10. And then you have the anabolic phase from the 3 even down to the 21. You have the endochondral stages from the day 5 to 10 to that of the 16 to 21. And then there will be the remodeling stage, which couples with it from the 10 to 16 to the 21 to 25. But my interest has to do with what is happening within this box here, vis-a-vis the days. So you have monocytes here, you have PMN, which is polymorphonuclear leukocytes, which we are talking about, the neutrophils. Then we have the macrophages, you have the T cells, the B cells, they are in here. That is from the day 0 to 3, because when there is the fracture, when there is the injury, the body must respond. Inflammation. And then even from the day 3 to 5, we expect that if anything, the debris and all the debris have been mopped up or cleared from there. And then by the day 5 to 10, you have the laying down of soft callus. And even there is unmineralized cartilage where you find the chondrocytes here, and you can see the osteoblast here. By this time, you don't see any osteoclast here. It's only the chondrocytes and the osteoblast. Then we come to the day 10 to day 16, where we have the hypertrophic chondrocytes, right? And then you have the introduction of osteoclast also here. By day 16 to 21, where we are expecting hard callus or secondary bone, you see that we have the myelopoietic cells, we have the hematopoietic cells, and you don't find the osteoclast and then the osteoblast here. But by the time that we are on day 21 to 35, we have the hard callus, and then we also have remodeling of the bone. And the interesting thing is, by this time, you don't find any monocyte or macrophage or PMN there. You only find the osteoblast and then the osteoclast, and you have the osteocytes. And remember what I told you, the osteocytes are actually matured osteoblast. Very important. Very important. Okay. So we go on. And for that, we are looking at the steps in terms of fracture and fracture healing. So at the moment of fracture, blood vessels through the Havasian system are torn at the fracture site. There is local hemorrhage and formation of a hematoma that fills the fracture gap and surrounds it. There is the formation of granulation tissue. So it forms the scaffolding for granulation tissue. And then there will be the inflammatory process that follows immediately after the injury brings in what we call the recruited leukocytes. And the recruited leukocytes we are talking about, this shouldn't be new to you because we are still in the phase of inflammation. So you know that the recruited leukocyte we are talking about is none other than the neutrophils and then the monocytes, because they are the first response or the initial call in terms of cells that will be released before there will be macrophages and the other mononuclear phagocytic cells. Then by the end of the week, the first week, your phagocytic cells have removed most of the hematoma, and then new vascularization, formation of new blood vessel, and initial fibrosis that happens to connective tissues are occurring. Then you have the granulated platelets, and then activated leukocytes will release the platelet-derived growth factor, PDGF. Is platelet-derived growth factor. Then you have the TGF-beta, transforming growth factor beta. Then you have the fibroblast growth factor, and then other cytokines. And these are actually released by the leukocytes to help activate osteoprogenitor cells. And it is out of that that you have the stimulation leading to osteoclastic and osteoblastic activities. And it's from the word osteoblast and osteoclast. And I've told you what they are. They are cells. They are bone cells. Yeah. So the activities of the osteoblast, the activities of the osteoclast. And if you have to go back here, you appreciate it better knowing when the osteoblasts were released, right? And when the our osteoclasts were also released. And remember that for these ones, there has to be mineralization. There has to be mineralization. Very important. There has to be mineralization. So from week 2, osteoclast clears away bone, necrotic bone, and osteoprogenitor cells deposit woven bone in the subperiosteal region and within the medullary cavity. Activated mesenchymal cells in the surrounding soft tissue differentiate into chondroblasts and lay down fibro and hyaline cartilage. In uncomplicated fracture, by the end of the second or third week, the fracture site is immobilized by fibrocartilaginous tissue called the soft callus, but not yet strong enough for weight bearing. And then the newly formed cartilage undergoes endochondral ossification and connects to the newly formed woven bone, resulting in the formation of bony callus. Then there will be mineralization. When mineralization happens, that's when you expect increased stiffness and then strength. Then during remodeling, the callus which is laid in excess is resolved whenever we place mechanical stress also on it. Okay. If the bone ends are not perfectly aligned, the volume of the callus that will be released will actually be greatest in the concave portion, not in the convex. If it is the convex, the possibility of fracturing again is very high, but it should be in the concave portion of the fracture site. With maturation and transmission of weight-bearing forces, the portions that are not physically stressed are resolved and the callus is reduced in size until the shape and outline of the bone is established, and expect that there should be some form of restoration with regards to the medullary cavity. And then we expect remodeling to be completed, and that means that if it is completed, we don't expect to find the site of fracture. We don't expect to find the site of fracture. That means we don't expect, if we go back to this part, we don't expect to find this hairline here. We don't expect to find any mark of fracture there. Okay. So in terms of healing of the bone, right, others would have theirs okay, whilst others would have theirs delaying, right? There can be delayed bone healing, delayed fracture healing. And actually, it's as a result of the bone involved, the fracture site, the fracture type, and in terms of the treatment, internal versus the external. It involves only the bone. But then when you have the complicated ones, the oblique ones and the displaced ones like that, obviously you know that tissue can even come in between. And in such regard, we expect that there would be some surgery to help take away the soft tissue, and know that when the soft tissue is also removed from in between, maybe the edges of the fracture, we
so if you couldn't
so we go on. Where is the class rep? Okay.
So Kaya or whatever. Oh.
So we have treatment complications, and we have other factors as for wound healing, right? Yeah, other factors as for wound healing. Okay. I think Benjamin's hand is up. I think it's gone back. Okay. So we go on. Okay, Benjamin, again, your hand is up.
Hello, sir.
You can unmute. Yes.
Please, I think it was a different Benjamin. So this is a different Benjamin too.
Oh,
Sir,
okay.
please, my question is with you talked about the phases of the three phases where we have the inflammatory to the the last phase, that is the remodeling. And then you said that the remodeling can happen from months to years. So let's say with someone who is active, like with a sports personnel, can remodeling still take place whilst normal activity?
Guys at the gym, so maybe they will start with the treadmill, right? Gradually to help with the remodeling, because
Okay,
you see, immediately the remodeling actually intersperses with the whole reparative process.
okay, sir.
So when the whole reparative process starts, they will start with bearing less weight or low weight, and then as the healing progresses, and remember that even with this one, there must be a diet plan, right?
Yes, sir.
Nutrients also to support the whole thing. So whilst he's going, then they will be increasing the weight as the healing process goes on.
Yes, sir.
And at a point, we'll get to know that he's able to now bear a lot of weight, and then he's now ready to play
Okay, sir.
or come back or return to the pitch.
Okay, sir. Thank you, sir.
Always welcome, Ben. Okay. So we go on. So in terms of the complications of fracture, these are not different from the complications we made mention of. Just that here we can have excessive deposition of the normal constituents of the callus, right? That can actually result in a challenge with the union. So sequence of events in the healing of fracture can be hindered or even blocked. And there are several factors that can delay or arrest the process. And movement is one of them. Movement is one of them. So when, just like Benjamin asked that important question, we can have the fracture reoccurring or recurring, can be one of the reasons. But then this same movement can be of help when we are looking at remodeling. It has always been that in the earlier stages of the laying down of the callus, where it is not bony yet, but it's tough, it's soft. You don't allow weight bearing, you don't allow excess movements and all that, right? Excess movements and all that to occur, because it can be the reason for non-union. Okay. So we go on. So I think Bismarck asked a question about the fact that open and closed fracture, which heals fast, is closed, please. It's closed.
Different person. I mean, this is the other one. Oh, this is the one. This one is now.
Today, your people, they want to tempt me, but I refuse to be tempted.
So
we go on. Osteoclast is not the same as ossification, please. So let's go on. So we have, when there is continued movement, that is what will lead to the pseudoarthrosis, formations of false joints. And then when you have interposed soft tissue, that can cause non-union. that can actually cause non-union. So please take note of that. When you have a tissue coming between the fracture, especially if it is the open type, and then you have the tissue coming in between. Where is your class rep? Class rep, where are
Hello.
you?
Please, we are here. But
So you are there, and then people are muting and unmuting and whatever it is. When I speak right now, you come and then come behind and be apologizing. But you have to do your work. That's why they give you your
please, the IT department didn't make us host today.
I said, why you are a host? You are a co-host. Can't you see? I was
Yes, please. He usually
I was controlling
make
the
us
class
host,
when
but today he didn't.
No, you are a co-host.
We have
you
a
are
lot
not...
of co-hosts here. So why you are even a co-host? Emmanuel, you are a co-host, or you don't see? Huh? You see, sometimes you should put yourself in our shoes. If you are at the back here, you are the one talking, busily trying to get somebody to understand, and the person is kind of not even serious and disturbing the whole class. Huh?
Sir, please, we have more co-hosts now. If anybody misbehaves, we will just take the person out. Thank you.
So we move on. Thank you to say. We move on to misalignment, and we are saying that displaced fractures heal slowly. Displaced fractures heals slowly and results in some deformity. And that is actually how some people have these shortened legs. It leads to shortening. Okay, then we have infection. And we all know that the single most important adverse effect in terms of healing, whether of wounds or fracture, has to do with infections. When there are infectious agents in there, the issue of chronic osteomyelitis and all that. Yeah. Okay. Okay. So we come to the comminution here, and comminuted fractures frequently results in deformity and predisposed to development of osteoarthritis. We have pre-existing bone disease, and here it has to do even with metastasis. If there are metastatic cancers for which the bone cells have been involved, very important. So if there are any bone disease, please expect that the healing process will be slowed, because whilst the bone disease is having a toll on the bone cells, you expect those same bone cells to be involved in the reparative process, which might not be possible. We have vascular insufficiency, we have malnutrition, and then we have vitamin deficiencies. All these are not new. Calcium and then phosphate deficiencies, systemic infections, and then we have diabetes mellitus. All these are actually just like what we talked about with regards to the factors that affect wound healing. I think Callisto's hand was up, but he's tired, so he actually...
So a picture that day. What picture no put that?
Yes, my hand is still up.
Okay, so Callistus, talk to us, please.
Yes, I want to find out whether there is any scientific proof that a fractured bone that has remodeled fully is stronger than the non-fractured bone, or is just a myth?
You see, from research and from the papers published, there is nothing like that. In fact, even if we are to consider, Callistus, if you are to consider normal tissue healing, right, wound healing, we know very well that after we've gone through the various phases and the various days, hours to days and months, right, for which you wouldn't even find there is proper epithelialization and everything. When you apply some bit of pressure to the place, you still feel the pain. Do you get it?
Right.
You still feel the pain. And there isn't any scientific proof in terms of that, unless maybe somebody has a newly published document, which I have not seen. But so long as I'm aware from published papers, there isn't anything like that.
Yes, sir.
Okay. And there are, you see, some, it's interesting because some of these things, there are conflicting views in terms of some of these ones. But I always tell my students that, first of all, whenever you are reading any published paper, right, check the journal first. Check the journal, the impact of the journal, and then look at papers that have been published in that journal. Some of them are predatory journals. This issue about prostate cancer and then having too much sex, right? There was this whole hula baloo and debate about the fact that if a man has a lot of sex with a lot of a lot of sex and with a lot of women and whatever it is, their chances of getting prostate cancer was very less. And there were also published papers that actually said otherwise. So for somebody like me, a scientist, what I would look at will be the journal involved, the number of publications. So I will look at, okay, those who are for and against, and in terms of the authors, right? Are they credible enough, or they just, if you have a publication coming from some Johns Hopkins University, you have some publications coming from serious places where there are professors from those areas, those ones actually holds weight more. So I'm just trying to help Callistus understand that this myth and whatever it is, if you want to prove, you can go to Google Scholar, PubMed, and other very good search engines. You type it in, the papers will come out, but you look at the journal, look at the artists, look at where the researchers are from, and then you can actually deduce and then either go for or against the motion. Okay. So I think Benjamin's hand is up again. Ben, your hand is up again.
Yes, sir.
Okay.
Sir, please, with the alignment in our clinical setting, it is quite common that most cases that get RTAs that come to the unit because of probably financial constraints opt to go for bone setting from our traditional bone setters. And then most of them, per my observation, most of them tend to come with shortened limbs. So with these cases, is there any hope for them with the issue of surgical management? Is there any hope for them to get back?
That is when the leg is shortened?
Yes, please.
For me,
can we do something for them?
In terms of something for them, then that means there should be a surgery, right? There should be a surgery, and then the possibility of continuity where there will be the introduction of certain metals to help with the adjustments. But if you are to think of it for a long haul, right? If you have to think of it for a long haul, if it's shortened, then the person is able to move about with it. Look at the financial constraints here. Look at the whole issue of are you the one going to now break bone? Are you like the whole thing? For me, I think that there will be no need of tampering with it. If in the first place they had the opportunity for us to do a surgery for them and to help, right? But then they never opted for that. They went and they had a shortened leg. Why don't you leave the person rather than taking the person through processes which can actually lead to further complications? Ben, do you get the point here?
Yes, please.
If in the first place, the surgical option is there for the person, they will be advised that we can do a surgery and then we can actually put some screws and here and there to help you and everything. And we'll help you with the whole remodeling process. You go to the physiotherapy units for them to help you with movement and all that. The person will still decide that, well, I know somebody across the street that can help me. And so they went there, and at the end of the day, it shortened.
Yes, sir.
Right? is shortened, why would you worry yourself again to tell the person, let me take you back to what you really what you really rejected?
Okay, sir.
Mm-hmm.
Thank you, sir.
Always welcome. Or you had a different opinion about that? Hello, Ben.
Yes, sir.
What were you thinking?
Oh, sir, this was it was related to this case. We had this guy at our facility about 2 years ago, Azari John. Then I was in the wound dressing unit, and then this guy had an accident. He came, and then the surgeon talked to him with regards to physicians. But I think the family were not in this, and were not in line with what the surgeon was deciding. So he went, and then after about 8 months, he came back with a shortened limb, and now I think he was ready to. He said the family were prepared because after going to series of bone setters, they saw that there was no hope for him to get to normal function, and his movement altered. So they then came, the family, someone outside the country was willing to support him get back to normal function if only the surgeon would, if only there was hope for him to get back to normal function.
But you see, here we know that you have to now cut the bone again. I hope you know that.
Yes, and then the surgeon was saying, I asked him, and he was saying he had to re-break again
and that was what I was saying, that it's looking at all that, the person going through all that, right? The issue of possible reinfections and other challenges that you can, or the best maybe you can do, which most people even do, will be you trying to ensure that there is shoe lift. And Pabuano that one for them, watching the normal one.
Yes, sir.
That might be the only thing that can be, for me, that's the best. But because I can't think about you breaking the bone again and then all that. And that's why when it comes to health decisions, right, it's always important that it's made prompt, and then it's made with various considerations. You know that most of our clients that come to the hospital, we give them advice, they don't take, they go back, right? They go back and then Regina says, so I'm not saying we don't break. I know they do break, but then you ask yourself, look at what the person will go through. And these things must actually be explained properly and documentations done, because when you do, and then there are underlying bone diseases, that's also another challenge. Because just like Benjamin was saying, he had gone elsewhere, they have given him some things to drink and then applied some herbs here and there and all that. You might never know what has started in there, right? If the person is also diabetic, you should also be aware of what you'll be dealing with. Because if you break the bone, you should also remember that then there will be a break in skin. If the person is diabetic, you should know what you are dealing with. So all these underlying factors must be considered before you jump on to start doing some, because it's just available. Some options and ligaments, we know we are dealing with dense fibrous connective tissue, and it will interest you to note that, right? If it will interest you to note that when we talk of healing of tendons and ligaments, we are also talking about repair. I told you for the bone, we were talking about regeneration. But when it comes to healing of tendons and ligaments, we are talking about repair. And we know that our tendons and ligaments help us to be able to bear tensile loads, right? Be able to transfer forces, and then they are strong, but then flexible. So we're able to carry buckets of water our brothers and sisters that help carry loads in towns and other places, you ask yourself why their hands and their neck doesn't break off or something. And it's simply because of our tendons and our ligaments. And it's actually composed of 78% water, 20% collagen, specifically type 1. And if you hear of type 1 collagen, you know that they are the ones that are able to bear high tensile, they have high tensile strength. It was the type 3 that had low tensile strength. Yeah. And so you have the tendons and then ligaments being fibrous connective tissue composed of 78% water, 20% collagen type 1, and then 2% proteoglycans. And please note that they have viscoelastic properties. Attach muscles to bone origins. Your tendons attach bone to muscles, to bone origin, and then you have insertions. Then you have the ligaments attach bone to bone, tendons, muscle to bone, ligaments, bone to bone, providing support to the joints. Whenever there is a rupture, the best way to go about it will be surgical repair, so that the edges can be brought close to each other, right? And it's always not advisable that when there is a tendon tear, you wait for a long time. Mostly when there is a tendon tear, it's advisable that surgeries be carried out as soon as possible. There will be migration and proliferation of fibroblasts. So you see, what I told you, we are talking about repair, we are talking about granulation tissue formation. That's why you are seeing fibroblasts here. Obviously, you should know that if we are talking about granulation tissue formation, right, then we are looking at formation of new blood vessels. No wonder we have capillary buds here. We have capillary buds. We have capillary buds here. We have capillary buds also here. So know that about 2 weeks into healing process, we expect collagen fibrils are oriented and rearranged into thick bundles to provide greater strength. During this period, immobilization relieves stress. Immobilization during this period, because if movement continues, the possibility of re-rupturing is high. Because as at that time, even the collagen that would have been laid would not be one which can allow strength or has enough strength to bear any form of weight. When healing has progressed sufficiently for adequate tissue integrity to be achieved, mobility results in remodeling. So collagen realigns, and this is where there will be the intra and intermolecular arrangements, cross linkages of your collagen. And it will take 40 to 50 weeks for tendons and ligaments to regain normal strength. It will take 40 to 50 weeks. That means that if all things are equal, right, we expect that if you have a tendon or a ligament, it might take you like almost a year, because we have 52 weeks in a year. 40 to 50 weeks of that matter. Okay. And remember, the scar tissue formed is weaker and has increased amount of minor collagen type 3, 5, and 6. And then there is increased proteoglycans and decreased cross-links. And you should note that the proteoglycans here, you know what they were for, and granulation tissue formation. We made mention of them, and then the fibronectin serving as scaffolds for the rebuilding of the matrix. No, Abigail is asking that if there are, when there is fracture, there is always tendon and ligament What is that? Tear. I'm sure you're trying to say tear. No, it's not all the time. It's not all the time, please. Okay. We have some minutes more. Let me start my other slide. So that, but God willing, next week, right, we'll have our midterm. Next week, we'll have our midterm. Let me share the other one. Okay, so we are looking at neoplasia. Ben, type your question. Type your question. Then we have neoplasia. Let's start with this. It's very important. So at the end of the lecture, we expect that you'll be able to differentiate neoplastic lesion from non-neoplastic ones. And then we have be able to contrast benign from malignant tumors, describe methods and mechanisms of metastasis, list the etiologic factors in carcinogenesis, and then understand clinical effects of neoplasms, understand the clinical effects of neoplasms, as well as know the diagnostic modalities when it comes to cancers, So we'll start with the definition. We have some definitions to consider, and the first one is tumor. We have some definitions to consider, and the first one will be tumor, right? People are saying the V class is giving them headache. Please, you can speak to your coordinator about it. Talk to your coordinator for him or her to speak to the IT guys, because that's the only available way to have your midterms done. So please do well to, yeah. So Beatrice, is because I told you that the processes, one actually has to do with repair. When it comes to the ligaments and the tendons, we are looking at connective tissue here, repair, and then one other has to do with regeneration. And in regeneration, we are looking at the same cell going through the cell cycle to produce daughter cells. You can answer it from that part. So let's look at the definition for tumor. It literally means an abnormal swelling, any localized swelling that is, and it now has much more specific meaning and is used to refer to neoplasm. So neoplasm means new growth. It means new growth, and it is actually an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissues and persists in the same excessive manner after the initiating stimulus has been removed, right? In terms of neoplasm, we are looking at new growth, and we are saying that it is actually mass of tissue, but then it's abnormal. and the growth of that would exceed, and the growth is actually uncoordinated, and even when the Now let's look at the features of neoplasm. The first one is the fact that it's autonomous or relatively autonomous growth. That means in terms of the growth of the cells, they are not coordinated. They are not coordinated. If you had a stimulus initiating the growth, they are autonomous. And when we go forward or we continue with the lecture, you appreciate why they are autonomous. Okay. Normally, cells do not replicate unless they are stimulated by growth factors, like I told you, where they are released in response to physiologic, pathologic, or reparative demands. So normal cells do not just get up and grow, or they just don't get up to replicate. There must be a reason. There must be the release of growth factors. And just the same way, in terms of the regulation, if we need the growth to halt, then you have growth inhibitors released. Yeah. And so cellular replication is regulated by growth regulatory mechanisms, and tumor cells called neoplastic cells, they escape permanently from these regulatory mechanisms, the normal one. And how do they do that? They escape it by transformation. By transformation. And what we mean by transformation will be the fact that there will be genetic mutations and there will be genetic alterations. And that gives it that autonomy we were talking about. That gives it that autonomy we were talking about. That gives it that autonomy we were talking about. Yeah. We have passed this stage. People are still asking questions on healing. Let me get to where I want to get to. Then I can come back to actually address your questions and all that. So just like I was saying, the transformation of the cell from the normal cell to a neoplastic cell as a result of genetic mutation gives it that relative autonomy or the full autonomy. The relative autonomy or the full autonomy. Very important. Then we have the benign neoplasm. We have benign neoplasm. In fact, in terms of the neoplasm, we have two. We have the malignant neoplasm, and then we have the benign neoplasm. If we are to look at benign neoplasm, right, the behavior of the tumor and the cells that make up the tumor seem to be innocent or innocuous. It seems like even though you have some group of cells that are growing, but then they have not broken the basement membrane, they have not invaded surrounding cells. And in terms of its resemblance to the parent cell, it looks just like the parent tissue, or it looks just like the tissue that underwent replication. There isn't any difference between them and the parent tissue or the parent cells they arose from. And so they are considered clinically innocent. They are considered biologically innocent in terms of behavior. And one interesting thing is you will find capsules around those tumors. You will find capsules around those tumors. You will find capsules around those tumors. Very important. And if you find those tumors, especially when they are benign, you can consider local excision. And I always advise people that have tumors, right, that if actually the pathologist finishes the assessment of it and they tell you what we are looking at is benign, let them excise it. Let them excise it, because you see, we have had instances where benign tumors have actually transformed to become malignant tumors. We have seen benign tumors transform to become malignant tumors. We have seen benign tumors transform to become malignant tumors. So benign tumors may cause clinical problems, and that is after a while. And those problems it may cause will be the fact that because of its size, it can actually exert some pressure on adjacent tissue. And the pressure it will exert on adjacent tissue will actually cause the adjacent tissue to undergo shrinkage. To undergo shrinkage. Okay. And then we have the fact that they can become bigger and lay their weight on vessels, whether arteries or veins, leading to the blockage of the flow of oxygenated blood or the blockage of the release of deoxygenated blood from an organ. These tumors also, when they implant themselves in the uterus or the endometrium, we know that they can lead to the production of hormones. And so there have been instances where people will come to the hospital, you take urine from them to test for pregnancy, HCG hormones, right? And then it will be positive. But the person will tell you, no, they don't even have a boyfriend, or they are virgins or something. No, they can't be pregnant. The only way people have been saved will be when they do a scan. Because sometimes when there is a tumor that implants itself within the endometrium, right, the probability that you have the production of certain hormones is very high. And so we must always confirm it's not all the results from urine, right, that is positive for pregnancy is truly because the person is pregnant. Sometimes it will be as a result of the implantation of a benign tumor within the endometrium. And it's not only in terms of pregnancy, but there are secretions of various kinds of hormones as a result of implantations of tumors, which are, or as the implantations of tumors, or the growth, that's the right word I want to use, the growth of tumors, right? The growth of tumors even within the endometrium or other parts of the body. Other parts of the body, very important. Then we have the malignant neoplasm. So for malignant neoplasm, we are looking at a tumor which is actually cancerous. So when we are talking about cancers, which is actually used by the public, generally used by the public, we are talking about malignant neoplasm. And every class that I have taught, I've always advised them in terms of their conversations around the nurses table, especially when your clients can hear what you discuss or what you say there. It's very important. It is very important that as a nurse, around the nurses table, you consider the words that you use. And so if you have somebody's cancer report and you are discussing the cancer report, it is always advisable to rather use the word malignant neoplasm rather than cancer, because the public knows cancer, right? But then very few people would know about malignant neoplasm. And in fact, it's even not ethical and advisable to discuss clients' reports or results at that place. But you see, most of us forget about all these things and then just sit there and then discuss people's results and conditions and all that. It's not right. It's wrong. So please, we should take note of that. Okay. And so when we are talking of malignant neoplasm, we are talking about cancers. And we know that malignant neoplasms would actually break the basement membrane and then they will invade, and at the end of the day, they spread. And that's where metastasis, they have the potential of spreading, especially when the roots of metastasis, when the channels of metastasis are close by. They are close by. Yeah. I didn't add this, that the benign neoplasms can undergo transformation to become malignant. And that was what I was saying some few minutes ago, that if it is benign and is confirmed benign by the pathologist, it's advisable they excise it or they remove so that it can't transform to become malignant and become a problem. Because when it becomes malignant and it gets the opportunity to spread, it has the potential of spreading because maybe it might be closer to lymphatic vessels, closer to blood vessels and all that, or pleural, pericardial cavities and all that, then it means that you are in big trouble. Okay. So now let's look at some information about the malignant tumors. They are typically rapidly growing, and they are poorly circumscribed due to their invasive nature. And when we are talking about their invasive nature, we are talking about this trying to spread to adjacent cells and adjacent tissues, right? Yeah. And then that is not all. They even trying to break the basement membrane. So strands of invading neoplastic tissue extending into adjacent normal tissue produce a crab-like appearance, and that is where the word cancer, which is a Latin word, comes in. So in terms of histologically, right, in terms of histology, we look at the cells and they do not resemble the parent tissue they originated from. In terms of resemblance, it's poor. And because of their rapid growth, they mostly would outstrip their blood supply, resulting in necrosis. Yeah. So they can grow big and then just rupture, cause the veins or the arteries to also rupture and all that. And we have seen instances where people have been transfused with a number of pints of blood, and after some days, you do HB for the person, and then you are not really seeing much. There has been people with very bad stage and grades of cancer, and for some of them, when we even spread Macintosh or they are on the bed, and then they get up, you can see that the whole bed sheet or the Macintosh that was used to spread there is actually having blood stains. Okay, so please take note of that. So there are invasions of walls of blood vessels and lymphatics that allows the dissemination of these cells, that is, these malignant cells, to other parts of the body. And the interesting thing is that when they get the opportunity of being spread through blood vessels, right, they attach at places and points and areas of the flow where the flow is slow. Right, so the areas where the blood flow is slow, that's when they get the opportunity to attach. And it will interest you to also note that in terms of the attachment, these cancerous cells behave like the inflammatory cells. You remember the complementary proteins that were sequestered on the surfaces of your endothelial cells, the P-selectin, the E-selectins, the ICAM, VCAM, PCAM, and all that. When they want to move from the blood vessel to other tissue, right, where they will form what we call the secondary tumor, they go through the same process we are talking about. That is, even within the blood vessel, so that they can escape from the blood vessel. And the reason why they are not identified is because of the transformation. The neutrophils and the monocytes do not see it as a tissue or a cell to be attacked, because they express most of the receptors on the surface just like the neutrophils and just like the normal blood cells would do. Yeah. Okay. Okay. So we go on. That's not all. You have ulceration, right? You have ulceration, which is common in malignant tumors arising from a surface. And then though all malignant neoplasms possess the potential to metastasize, not all of them spread. Not all of them, because there are some that are actually far from the roots of metastasis. There are certain tumors that are far from the channels of spread. And here we are looking at carcinoma in situ. That is carcinoma in situ. But then the ones that spread widely, right? The condition of widespread metastasis is referred to as carcinomatosis. So when you have malignant neoplasm spreading to various organs, right? We are looking at a condition known as carcinomatosis. And it's very sad that you can have a cancer, the primary tumor can start somewhere and then it can spread to other parts of the body. One gentleman that went to do a PhD outside Ghana, in the final year of his PhD, the gentleman had a cancer and they detected that it had spread even to the optic nerves and spread to other parts of the body. And that means that all hope was lost unless God helps the person. Because in situations where you have various secondary tumors here and there in very sensitive organs, it's just a matter of days and time. And that's how, looking at the staging, it's actually the staging that helps us know how the spreading has gone, right? We equate staging to the metastasis, whilst we equate grading to the resemblance. Whilst we equate grading to the resemblance. Okay. So we continue. So we go on, and then we have the malignant and then adjacent tissue. So it's very important. And then you have metastasis here. You have blood loss from ulcerative ulcerative surfaces. Then you have the obstruction of flow. There is production of hormone, ectopic hormonal production, paraneoplastic effects, and then you have pain. And then you have pain. Okay. You have pain. Okay. About resemblance of the tumor to the parent tissue, right? And we have the low-grade tumor, we have the high-grade tumor, we have the moderately differentiated tumor. And the moderate one is between the two extremes, low and then the high grade. And whenever we are talking about the low-grade tumors, it's actually well differentiated and bears a close resemblance to the cell or tissue of origin. But the high-grade ones, they are poorly differentiated. And it's based on that we have grade 1, grade 2, grade 3, and you have other grades out there, even grade X. Okay. So whenever we mention grading, please know that we are equating it actually to the resemblance. How does the tumor resemble the parent tissue from which it grew from. But we do not do grading for benign tumors. Reason is because most benign tumors, right, have they are from their they resemble their parent tissue. They resemble their parent tissue. Benign tumors usually resemble their parent tissue. There is no need for any form of classification whatsoever. No need for grading and all that. Ohene is asking that please, can abnormal growth on the skin, as in wax, be regarded as benign tumor? No. That's if it wasn't congenital, but as a result of human papillomavirus. No. Okay. So that is basically what is happening. So we don't grade benign tumors. We actually, because in fact, you can't even consider keloids even under this. Don't forget, here we are talking about same cells, right? Going through the cell cycle to produce daughter cells, differentiated, and they are not matured. In terms of even keloids, we are talking about overlaying of collagen. We are not talking about the cells replicating. Okay. So that is basically it. Then we have anaplasia. And for anaplasia, it's used to describe the situation where a tumor is so poorly differentiated that its cell or tissue of origin cannot be determined from its microscopic appearance. Yeah, that's anaplasia. So poorly differentiated that when you look under the mic, and this is where the grade X I was talking about, you are not even able to relate it to any cell within the body. And here, there is a way you can do that. If you are looking at a secondary tumor and you are suspecting that it might be related to a certain primary tumor, you take biopsies from the two, right? And then you try to test for carbohydrate. You do carbohydrate testing, and if the secondary tumor was actually from the primary tumor that metastasized, then you see that the carbohydrate content will be the same thing. The carbohydrate content will be the same thing. And this one is quite a histopathological technique where you have to do what we call the periodic acid skip or the Gaussian blue staining. Anyway, the grade of a tumor correlates strongly with prognosis. That is the survival or the mortality, and often determines the type of treatment. Often determines the type of treatment. Often determines the type of treatment. Okay. I would want to end here. And then continue from nomenclature, God willing, next week. That is, next week we said we are doing the midterm. So we'll do our midterm. But class rep, please get in contact with me to confirm or otherwise. Yes. Well, somebody is asking, why do they get bleeding? Because of the outstrip of their vessels. And then I think Comfort Bar was talking of palliative care for the cancer patients. Well, it's true, but then to what extent? To what extent? To what extent? Yeah, I think the rest is nothing to really worry ourselves about. Okay, so since there are no questions, somebody is asking about areas for MISM. Areas of MISM. MISM will be from introduction to healing. MISM will be from introduction to healing, please. From introduction to pathology to healing. Introduction to pathology to healing. Yes. Any other? Yeah, introduction to pathology to healing. I had problems with, okay, so class rep, after the lecture, WhatsApp me and let me send it right now. The way people are asking for slides, don't worry, I'll give you. Somebody is asking if it is objective. It's actually assertions and reasoning. Assertions and reasoning. Assertions and reasoning. We are looking at, so I think let me advise on this. We are looking at about 30 to 40 questions, but the total of the question actually is 100. So it will reshuffle. The system will reshuffle the 100 questions. And so let's say if Emmanuel Arthur's question will be maybe the first, it will pick randomly. One here, one there, two, that kind of thing. And then it will not be displaced all at a go. So it will come one after the other like that. And you'll be racing against time. So you should note. And make sure that please you get a good network, right? The question is 30 to 40. That means that if the questions of Emmanuel Atta might be different or will be different, not might, will be different from Sewa Ej's questions. And so if I'm advising because it has happened before, some students actually ask for answers from their colleagues and then immediately they had it, they just read and they will be inputting the answers like they got 0 because they'll be reshuffled. So maybe their number 30 will be your number 5 or number 1 or something. And there are 100 questions and you have 30 of them to 40 of them being selected at random by the system to you. So take note of that, please. Very important. Julia, don't open your eye like that. Flies will get into your eyes. Some dirt will enter your eye. So don't open your eye like that. So that one, the IT should make the network favorable. You have to speak with the IT gentleman. I don't know how you get to them, but I think they are doing their best. I don't know. I'm sure it might be where you are. If you find a place where your network is good, please make sure, right? Somebody is asking if there is a chance to recover from malignant tumor. There isn't any publication like that, Ben. There isn't. Yeah. Okay. Thank you, Beatrice. So yeah, the network gets a good place. For when it's time for it, if you have to go and beg a place where their network is good, don't go and be in your room knowing that the network is not good. And make sure that if your place MTN is the best, use the MTN. If it's Vodafone, use the Vodafone. Please. The issue of it happening, you are asking of the time. The time will be my time of lecture. The 4 to 6. Yeah, 4:15 to 6:15. I think some hands are up. Let me see. Grace, please unmute and talk.
Sir, please, good evening.
Evening,
Please, about the
Grace.
network issues. Today we faced similar thing and it affected all of us. We had a midterm on research. Some were able to catch up with time. Some of us, when we try joining, it will log you out. We're not able to do it. So later on, the lecturer have to talk to the IT management and we have to start all over again. Both those who did it first and those who couldn't do it. So that's why we are pleading that maybe you talk to them before we start, so it doesn't be okay.
That's a good information. Thank you for that, Grace. I'll do well to speak with them, and then hopefully that doesn't happen during your time. Okay, so I think our time is up. Let's end here, and God willing, tomorrow. I said tomorrow, so sorry. God willing, next week we'll meet. Thank you very much.
Thank you, sir.
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 Pathology questions.
Thank you, sir.